Okay, so let's continue. So we were speaking about nitric oxide, and we kind of established the link between nitric oxide and serotonin, and why we mentioned earlier that the vasodilatory effect of serotonin on nitric oxide, serotonin on the blood vessel walls or the endothelia is an indirect one. And we've learned that, serotonin, when it is released, causes the synthesis of nitric oxide synthetase from the amino acid known as arginine, and then it is this nitric oxide synthetase that produces um, that catalyzes the production of nitric oxide. Now, other chemical mediators also include lysosomal constituents, and we have learned and established well that the lysosome is the organelle found within all cells, but we are talking primarily about the neutrophils here that contain lysozymes or enzymes that are able to break down any foreign substance that are not supposed to be within the body. Okay, so the constituents of the lysosomes, we have two main types. We have the primary type of lysosomal constituent, and then the secondary type. The primary type are called azerophilic, also called non-specific constituent. That they are non-specific. That means that irrespective of what type of substance or organism or dead cell that's the neutrophil has phagocytosed, these primary lysosomal constituents will act on them. So it is the same for them. They are non-specific. So it is the same myeloperoxidase, it's the same lysozyme, it's the same acid hydrolases that will be put on, whether you are a bacteria or whether you are a necrosed cell or whether you are a protozoa or whether you are whatever. So it is the same. They are the same. That's why they are called azerophilic or non-specific. The secondary ones are specific. Okay, they are specific. We have specific lactoferrins for specific types of what injurious agents. We have specific alkaline phosphatases for specific injurious agents. When whatever cause of injury contains collagen, there are collagenases that will break them down. So that is the primary and then the secondary lysosomal constituent. We also mentioned free radicals, and we said that the free radicals are kind of byproducts of oxygen metabolism in the cells, especially within the mitochondria. And even though they are produced naturally, they are very harmful, and their accumulation is not to the interest of the cell. Of course, if you eat the food that you are supposed to eat, the byproduct, the thing that you don't want, that has to come out. It needs to come out. If it stays in your intestines, you know where you are heading to. I think the same thing, or it's an analogy, that after the free radicals have been produced through aerobic respiration, they have to be packaged well, handled properly, and then sent outside the cell. Now, some of these free radicals are stored, especially by the leukocytes, the neutrophils, for degradation of what? Foreign bodies that invade the body. And major examples that we have superoxides, we have peroxides, and we have the hydroxyl radical, which is produced from the metabolism of water. And these are very dangerous, especially the hydroxyl radical, very, very potent. And I mentioned the last time that with the interaction of radiation with the body tissues, a lot of hydroxyl radicals are produced. And so we collimate our exposure, area of interest in the body, the person's organ, so that we don't unnecessarily expose unaffected or non-sick tissues, only tissues that we don't have any interest there, so that we don't increase the production of these hydroxyl radicals in there. And as we've said, they are very, very destructive. That is why Max International is producing their glutathione um, drugs and supplements, so that the body will be energized to be able to handle these free radicals well. We also have neuropeptides. Neuropeptides, so they are peptides, proteins that are produced by uh, the central nervous system, the neurons, and examples of them are substance P. Substance P, that's the name. If you don't know, you actually know the name of the molecule yet, so they call it substance P. Then also we have the neurokinin A. So when there is acute inflammation, what are the outcomes of acute inflammation? What are the possible um, products? What are the possible pathways that acute inflammation can result into? Most acute inflammations go into 100% complete resolution when there are no any serious genetic diseases that are going to interfere with the production of these chemical mediators and with the production of our neutrophils, and nothing going to interfere with vasoconstriction and vasodilation. We expect that the acute inflammation will result in 100% complete resolution of the inflammatory process, so that the inflammation can come into an end. And then the tissue can what regenerate itself. There is going to be replication of cells to replace those cells that died through the inflammatory process, through necrosis. Also, there can be an instance whereby after the inflammatory process, there is no resolution. There is no complete resolution. The tissue now is unable to regenerate, to replicate, to make up for what the lost cells that died during the inflammatory process, maybe during collateral damages, or during the actual insult, or during the actual bacterial infection. So the wound is going to heal all right, but normal tissue, as before, it is not going to what replace the dead tissues. Now you are going to have scar tissue, the body's way of patching. Or we are going to proceed into a chronic inflammation, whereby, irrespective of the bodies of the neutrophils or the system's inflammatory efforts, the acute inflammation could not remove or clean up all the infectious or injurious agents. So we moved to chronic inflammation, which involves more potent and then stronger um, white blood cells. We talk about the monocytes, the macrophages, the mast cells, and the lymphatic cells. Now, we have a lot of morphologic patterns for inflammation, for acute inflammation. The exudates can be serous, that is watery. It can be fibrinous, blood containing, or it can be suppurative, which contains pus, or it can be ulcerative, leaving a sore. I think I wish I had image. I'll show you images later. Now let's look at the chronic inflammation. In chronic inflammation, there are two main uh, type of neutrophils that are the major actors here. Unlike acute inflammation, whereby we have the neutrophils, the the polynucleated neutrophils. In chronic inflammation, we have the mononucleated neutrophils, talking about the lymphocytes and then the monocytes. Now, when the monocyte is within the blood vessel, it is called the monocyte. When it gets into what? The 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 tissue spaces is called macrophage or histiocytes. Now, what are the causes of chronic inflammation? When the cause of infection is persistence, okay, when the cause of inflammation is persistent, when as the the inflammatory response is ongoing, the exposure to the injurious substance is persistent, it is prolonged, it is continuous. So when that thing happens, we would transition, the body will transition from what? That acute inflammation into what? Chronic inflammation, whereby different types of white blood cells are now going to be what? Enrolled or recruited to the side of inflammation. So persistence of infection, or when there is prolonged exposure to insult, or when there is autoimmunity. Autoimmunity is a situation whereby the body's own white blood cells, the body's own immune system is fighting against the body's own tissues. So far as there are body tissues and there are body immune systems, and these people have decided that they are not going to sit together in peace, they are going to get what? A chronic inflammation. An example of such disease is diabetes, the type 2 diabetes. Another example is rheumatoid arthritis. You see that the body's own immune system is attacking these tissues, attacking the islets, uh, pancreatic islet cells, attacking what do we call it? The joint, the tissues that make up the joint of the palm, the hand, and co, and other types of autoimmune diseases. Are you following? All right. All right. Thanks, Dia. Thanks. Now, there are cellular players in chronic inflammation as well. And so, as I mentioned, we have the lymphocytes and then the histiocyte. I said that macrophages they are monocytes that graduate from within the the blood circulation into the tissue spaces, and they are now called macrophages or histiocytes because now they are living amongst the tissues. Histology, histio, tissue. We also have plasma cells, eosinophils, mast cells that play their roles in chronic inflammation. So the morphology, we can have infiltration, we can have tissue distraction, and we can have healing. So infiltration, what is infiltration? What is infiltration? There is prolonged what? There is prolonged um, there is prolonged exposure to what? The particular injurious agent. One example is when we were looking at TB, pulmonary tuberculosis, and we mentioned that in pulmonary tuberculosis, the Mycobacterium tuberculosis, which is the bacteria that causes tuberculosis, becomes so strong such that during the acute phase of the inflammation, the neutrophils are unable to handle, they are unable to clear, they are unable to kill the, the bacteria. So we will transition. The neutrophils will release chemicals that will recruit monocytes, lymphocytes, mast cells, and what have you. All these higher, more stronger, and more long-lived uh, leukocytes. Now, in TB, even though these are more potent um, white blood cells, when they themselves come, they are not able to readily remove the Mycobacterium tuberculosis bacteria. So what they do is that they rather concentrate their potencies together and then form something like a wall, an amorphous wall around the site of infiltration, the site of infection, so that they prevent the spread of what? Of the bacteria to other parts of the unaffected tissues. Okay. So we also have tissue distraction and then healing. So this is a granuloma or granulomatous inflammation. So you can see that in this in the middle portions, in the middle portions of the granuloma, this place, oh, this is so big. In this portion of the granuloma, in this portion of the granuloma, we have something that looks like liquefactive necrosis, or maybe uh, coagulative necrosis, or whatever, what type of necrosis. Now, just beyond them, we have the concentric arrangement of what? White blood cells, monocyte, monocyte, around the the zone of what? Infiltration. So that in case the mycobacterium that is concentrated here want to grow and affect the tissues beyond this territory, that time they wouldn't be so plenty. The number of mycobacterium within that area that is trying to spread wouldn't be so numerous. So this wall, these soldiers on this wall will be able to what? Contain them and kill them. So you see that there is going to be chronic infection happening here, chronic inflammation happening here, and then there is this wall guarding the other normal tissues beyond or outside that wall. That is a granulomatous inflammation. So there are two things that can happen. It's either eventually the patient gets some medicines or something that boosts their immune system, so that this granuloma, this collection of white blood cells, will eventually kill the bacteria from the peripheries until everything is resolved. Or the patient's immune system is going to break down, and then the granulomatous infection is now going to spread to other tissues. So that is the bane, that is the issue that TB patients are dealing with. And please, especially those who are X-ray patients, X-ray radiography students. When you go to the department, you go to the radiography department. Be very very careful, especially with TB patients. Make sure that you put on your nose mask all the time, or make sure that the patient has put on their nose mask. Sometimes you see them, they will leave their nose and put the nose mask on their mouth. When you ask them, say, my breath, mush. Doesn't tell me patrol. Share, why? Share, maybe you see here now. Share, where they are. So, granulomas, the granulomatous inflammation can cause that caseation, as we see in TB patients, caseation. So let me show you a chest X-ray that shows TB. Tuberculosis chest X-ray. So you see, we are comparing the normal chest X-ray. Can you see my screen? You are comparing the normal chest X-ray. This is the normal chest X-ray. Normal chest X-ray. Beautiful. The person has a nice chest. Normal chest X-ray. Then compare it to the tuberculosis chest X-ray. You see that in the tuberculosis, I mentioned the last time that tuberculosis mostly affects what? The apices of the lungs, where blood perfusion is poor. And if blood perfusion is poor, it means that there are less white blood cells up there. And if there are less blood cells up there, it means that we are going to have lower defense. So the tuberculosis is going to be able to proliferate there. Look at how the Mycobacterium tuberculosis infection, the granulomatous infection, has been able to just destroy these portions of what? Of the lung, the apices of the lungs. And now the body has now replaced those places with what? With fibrous tissues, with scars. Okay, with scar tissues. So in this case, instead of we having lung tissues like as it is here, we now have scars, fibrous tissues. So it is going to impair the function of the lungs. Let me see if we can get more images. Tuberculosis, chest X-ray. You have one here. You see how the tuberculosis infection has caused this particular portion of the lungs to have an increased density. Please, are you able to appreciate what I'm showing you? All right, let's quickly go and finish up with it. with everything. (6:30). Okay, let's finish this up. Now let's look at some systemic manifestations of inflammation. Systemic manifestations of inflammation. So, during inflammation, when these inflammatory chemical mediators get into the circulation, we are going to have fever, and we mentioned prostaglandins and these neuropeptides as causes of the fever or chills. We also have C-reactive proteins. Go and find what they are. C-reactive proteins. We also have acute phase reactants, alpha 1, alpha 2. There is going to be what? An increase in the erythrocyte sedimentation rate. Why is it that we have an increase in erythrocyte sedimentation rate? Find out. I won't tell you. Leukocytosis. What is leukocytosis? Find out. There is also going to be what? An increase in what? Pulse rate and blood pressure. Then you are going to have the effects of these cytokines, these chemical mediators, are going to be what? Observed in the tissue or the particular area where we have the infection. Tumor necrosis factor R1 and interleukin. So, all right, thank you so much. This is the end of this particular topic. In our subsequent meetings, I hope we meet in class. We will start with wound healing, and regeneration. If you go to the Washington D.C., the pathology playlist that I sent you, you'll find videos on a video on the regeneration and wound healing. It is just next to the inflammation. So go through it. When you meet in class, I'll use that same, and then we will move ahead and learn. Then also you can find more past questions. The same place where I showed you the questions where we worked on them. You can find some there. You can also look for some in your textbooks and all that. So thank you so much. Thank you so much. Don't worry, Yapon.